we try to mute all. We keep your audio and video both muted so that the session is not affected. I request Bidri sir to introduce Dr. Manisha ma'am to the audience. Over to you, Bidri sir.
So, good evening, everybody.
Good evening, sir.
Good evening, Bidri.
Dr. Manisha, she's a neonatologist in JNMC Belgaum. She's a wonderful teacher, and she's a neonatologist trained in UK. She's very good neonatologist, and it is very. We are all happy to hear her from her feeding of low birth weight babies and the problems we encounter in day-to-day practice. Thank you, Manisha, madam, to give this talk.
Sir.
Yes.
Shall I share the screen? Hello, everyone.
You are audible, ma'am. Put it in slideshow mode.
Yeah, okay. You can see the screen?
Yes.
Okay, yeah. So shall I start?
Please start, ma'am.
Okay. Good evening, everyone. And it's my pleasure today to talk to all of you through this media of webinar. And at the outset, let me thank NNF Karnataka for giving me this opportunity to talk on this very common topic, which we and with the problems that we face day to day. This one saying which we all have heard of, there is no finer investment for any community than putting milk into babies, was said by Winston Churchill. And we know as the years have gone by how important it is to feed our babies, and especially our IUGR babies. So my topic today is feeding low birth weight babies. And when we say low birth weight, we are talking about those weighing less than 2,500 grams. Now this comprises of term, preterm, SGA, AGA, babies with intrauterine growth restriction. So it's a whole syndrome complex when we say low birth weight babies. And if we look at the feeding issues for all these babies, there are plenty. It starts with which milk, when and how much, which method, what to feed in sick neonates, and about human milk supplements. Now, in this session of 45 minutes, it's just not possible to cover all these issues. So what I'm going to talk about mainly is which milk, when, and how much. As far as possible, I'm going to cover these topics. Methods in sick neonates and human milk supplementation, which includes total parenteral nutrition, giving additional supplements to the babies after they have reached to full feeds, then the feeding when they are discharged, all those things I'm touching about today. So because I'm mainly going to concentrate on minimal enteral nutrition, the problems associated with that, we are going to look at the literature review, and then we are going to look at what should we do in presence of abnormal Dopplers in the antenatal period. Okay, to start with which milk. Now, after having listened to the two eminent speakers on Sunday, Madam Asha Benkappa and Dr. Srinath, I'm sure there is no doubt in anybody's mind that the first and foremost is the mother's own milk, which we want to feed our little babies. And if in case, if that's not available, then we have the next option of donor human milk. And of course, the third option is of formula milk. enough has been said about what is the best option. And so again, I'm not going to touch upon what are the advantages, disadvantages of each of these. We know mom is the best, and that's what we are going to, that's what we are going to proceed with. And then how to feed. And that's where we are going to talk about the oral swabbing and the minimal enteral nutrition. Then we are going to talk about then the other methods, which are is gavage feeding, katori spoon feeding, and direct breastfeeding. Now, we all know a lot about gavage feeding, spoon feeding, and direct breastfeeding. I don't need to touch upon again. So I'm going to mainly concentrate on what is it about minimal enteral nutrition and a little bit about oral swabbing. That is with the colostrum. So with this brief introduction, let me go about, as I said, about the which milk that we are going to use for the baby. Mom's own milk has been proved beyond doubt, and it is not just related to the somatic growth of the baby. As Madam Asha Venkappa also highlighted the other day, the chronic diseases of childhood like asthma, the neurodevelopment of these little babies, and the adult onset diseases like obesity, hypertension, they all are related to the gut microbiome. It has been proved that the gut microbiome plays a very important role in the terms of epigenetics also. Along with that, the growth of the baby, which should happen in the first 1 to 2 years of life, and the gut brain axis, which affects this neurodevelopment, the behavioral problems in the babies. And all this has been, again, it's been proved that a lot of research is still going on, but all this, the research is pointing towards, it is related, it starts right at the time of birth. The mode of delivery, the normal delivery affects the gut microbiome. Mode of feeding, a little bit about this I would like to say here, is the research which is the literature which is being pointing out towards is we are talking about express breastfeeding, express breast milk, and giving them by katori gavage feeding. Yes, that is the option that we have when the babies are not able to take breastfeed. However, the literature is also pointing towards that if we go for spoon feeding or tube feeding, there would be some amount of nutrients which may be lost in this whole process. And at the same time, we may be changing the microbiome of the milk that we are feeding the babies. So breastfeeding is the best option. However, we are worried about that less than 32-week babies, we may not be able to breastfeed. Yes, but again, there are a few papers which I came across which shows that don't just look at a 32-weeker or a 33-weeker baby. Look at the clues. Look at, is this baby ready to take breastfeeding, and start feeds as early as possible. Put the baby to the mother's breast. That whole this together of the mother and the baby feeding at the mother's breast, that is what is the most healthy thing that should happen, not just to a term baby, not just to a term IUGR baby or a low birth weight baby, but that's something which we should try to look if we can push for even the preterm babies. And maybe a future research may say that yes, start breastfeeding the babies as early as possible, though there are no enough evidence right now, but the literature is pointing towards that even at 31 weeks, 32 weeks, put the babies to the mother's breast and stimulate breastfeeding and let them start feeding through the breast directly. Human milk supplementation, there is a lot to say about it, which I cannot cover in my today's topic. Total parenteral nutrition, and then the supplements which need to be given to the mother's milk. If we are giving exclusive mother's milk, if we are giving formula feeds, what to add, how much to add, again, that's a whole different topic by itself. So that which cannot be covered in today's topic. Environmental factors, antibiotics, the role they play in this gut-brain axis, in gut microbiome, again, we have to remember, because finally we know that the number of low birth weight babies and the preterm babies is, especially the preterm babies, is increasing. And if we want to ensure that these babies, they grow up to their full potential in neurodevelopmentally, as well as they don't have those adult onset, if they're not prone for these adult onset diseases, we need to look at all these things, and it starts all right at the time of birth, along with the first feed that we give to the baby. So with this, and we all know about this, if you look at this logo, Mom's Own Milk, this is the logo of the jewelry, this, which is there, I think, a UK based company. So they have used this logo for the jewelry. So it's as precious as that. So we are very clear now that we want the mother's own milk when we are feeding our low birth weight babies. When do we start it? I had listened to Dr. Joseph New for one of those Hippocrates session by Dr. Hariram sir. And I was really very impressed by some of the slides which he had shown in this seminar that time. And one of the slides is this, which I remember very clearly. Elsie Widdowson is a very eminent nutritionist from UK, and she did a lot of work during Second World War time. And they did a lot of work on the piglets or the animal studies. And this is what she said, is even a piglet, when it start feeding, the baby gains, the pig's duodenum gains 42% of its weight in the first 24 hours after birth. So this itself shows how important it is to start feeding a baby immediately after birth. So the concept started somewhere during that time, that people, those taking care of the little babies, started understanding that it's immensely essential that we start feeding these babies in the first 24 hours of life. And then a lot of studies started coming in. What is the benefit of feeding these babies in the first 24 hours or as early as possible? And this is a very interesting study which was by Lucas et al. In 1986, wherein he looked at, these are the babies who are, if you see, it shows the plasma concentration of these various hormones, that is enteroglucagon, gastrin, gastric inhibitory peptide, motilin, neurotensin. All these are needed for the normal development motility of the gut. And what he showed, that the percentage of these hormones in the babies who are unfed, or those who are well and fed, or the babies who had respiratory distress syndrome but were fed in the first 6 days of life. So if you can see that the hormone levels were nearly the same as that of the well babies, when even these babies with respiratory distress syndrome were fed in the first 6 days of life. So it's as early as in late 80s, early 90s, everybody started understanding the importance of minimal enteral feeding. Another very important aspect of enteral feeding is related to gut permeability. And when we had the session on necrotizing enterocolitis, this was pointed out. This was a nice study which was done on sugar absorption test in those who were fed, who had started with minimal enteral feeding, and those who were not given enteral feeding. And then they had given them the sugar, and then they looked at the excretion in the urine. And it was very clearly shown in this is those babies who had received minimal enteral feeding had decreased excretion, which means they had the decreased absorption compared to those who were not enterally fed. This was a very nice study by Elberg in 2004, which shows the importance of minimal enteral feeding. Then there were studies which were looking at the flow, this SMA flow. Of course, I will talk a little bit about this later on also, superior mesenteric artery, what is its importance. But again, this was another study which had come in 2004. It showed that how the flow of SMA increased in those who were fed enterally, while it remained low in the babies who had received total parenteral nutrition. And this is the mucosa of of piglets. This is in animal study, those who were fed enterally and those who were not fed enterally in the first week of life. And we can clearly see the disruption in the gut mucosa which had happened because these babies were not fed in the first week of life. And then this was another one which looked at what happens to the liver and the apoptosis in neonatal piglets after 7 days of enteral nutrition versus total parenteral nutrition. And this is hematoxylin staining of the liver cells, and it shows that how it has got disrupted with fatty liver, which happens because of total parenteral nutrition for more than 1 week when they are not fed. So all these studies indicate very clearly the importance of minimal enteral nutrition, which has been proved beyond doubt that it is beneficial in case of neonates in the beginning. So this is just a summary. They have found there could be mucosal atrophy, there could be alteration of in the intestinal microbiota, there is increased addition of molecules and polymorphonuclear attraction, systemic inflammatory response, this parenteral nutrition associated sepsis and liver diseases. So this is all because of the lack of trophic hormones that is acts as a stimulus for the growth of the gut in the first week of life. Just when we had started understanding that yes, minimal enteral nutrition is important in the first week of life, beginning of the last decade, somewhere in 2001, 2002, we started realizing the importance of absent or this reversal of the end diastolic flow detected, that is abnormal Dopplers detected during the pregnancy. Now, it is during that time that everybody started realizing that the percentage of even the low risk pregnancies may have as much as 4 to 6% of the mothers with abnormal Dopplers, whereas in case of high risk pregnancies, especially in case of IUGR, which is early onset IUGR less than 32 weeks, we may have 30-40% of the pregnancies wherein there could be abnormal Dopplers. Now, I'm not going to talk about the changes, what happens when there is an absent flow or the reversal of the flow in the umbilical artery, because that has again been discussed in detail very beautifully in the previous webinars. So I'm not I'm not going to discuss about it. What I'm going to just discuss in short is this is what happens when there are abnormal Dopplers. So there is antenatal gut hypoxia. We know there is cerebralization of the blood flow, that the body is trying to protect the brain at the expense of some of the other organs, and one of that is important organ is the gut. But what happens after birth, after these babies are delivered, is there is still the persistence of the disturbances in the gut perfusion. So what is there antenatally, it continues to remain postnatally also for some time. Along with that, when we feed this baby, definitely there is a metabolic demand of feeding. So there should be increased blood supply to the gut for the absorption of the feeds which have been given. So total what happens to the gut is there is poor tissue oxygenation, the stasis because the motility of the gut is affected. Along with that, some immunological factors play in. And then there may be some role of reperfusion injury also, what happens, like what we know happens in hypoxia. All these issues puts the baby at risk for necrotizing enterophilitis. So this was something which started becoming prominent beginning of the last decade. And then the lot of studies started coming in regarding minimal enteral nutrition beginning of the last decade. So if we look at just in short, what is minimal enteral nutrition? What is it defined as? Practice of feeding small volume of enteral feeds in order to stimulate development of immature gut. Some call it trophic feeding as well, gut priming, hypocaloric feeding. It has been called by different names, but conventionally it was defined somewhere in 2001. McClure was the person who has done a lot of studies in this, that giving small volumes of milk around 12 to 24 ml per kilo per day intragastrically gastrically starting within first few days of birth without advancing the feed volumes during the first week postnatally. That was what was the definition of MEN when it started. And then it was adopted into clinical practice as an alternative to complete enteral fasting, because the previous studies, what I had shown, had clearly indicated that it affects the absorption and the motility of the gut. So it was McClure et al. In 1999, 2001 he was the one who started with a lot of this studies in this particular field. And one of the studies which came up in somewhere around 2000 2001, wherein he studied less than 1750 grams babies who were requiring ventilative support. Half of them he gave it trophic feeding, half of them he just kept them enteral fasting, and then started with nutritive milk feeding after 1 week. And he clearly showed that those babies who were given trophic feeding, their weight gain was higher than the babies who were kept fasting enterally. So this was the conclusion which came up because of his study. However, in 2005, we always look at the Cochrane, what is the Cochrane analysis that we look at, which gives us some guidelines of how to go about. So Tyson et al. In 2005 and in 2007, again, he looked at the trials which had been given. And then he comes out with a conclusion that it is unclear whether trophic feedings are beneficial and relative to no feedings or advancing feedings for high-risk infants. Now, what happened during this time is there was a lot of heterogeneity of the data which was collected. The methodology was different, and probably that is why it was found, this was the conclusion that what came up. Darling et al. In 2005 also did a review, and he started his studies, and Dr. Darling has come out with a lot of studies with regards to this, and some of our own colleagues have worked with him in UK, and most of the studies which relate to this have been done in UK and North America. That is what I realized when I was doing the literature review. So he did a study, he looked at how is the feeding in growth restricted preterm infants with abnormal antenatal Doppler results. And because that was the time, that was what was the most worry. And again, there was a query whether, the incidence of NEC can be increased in babies who had fetal abnormal Dopplers. So this was around 15 years back, that still there was a query of whether we should give MEN or not. So then these are the queries which started coming when we think of feeding low birth weight babies, very low birth weight babies or extreme low birth weight babies. How early to start feeding, how much to feed, how fast to feed, what is the target? And that is the questions which we keep asking ourselves when we start our taking care of our babies in ICU. In 2011, so how do we feed? Now, the only option we have when we are talking about VLBW, ELBW babies is that since their suck and swallow is not very well developed, we prefer to do gavage feeding. Now, should this be a continuous feeding or should this be a bolus feeding? These were the questions which came around that time, and this was one of the reviews which was done of nearly 7 trials of including 511 infants of continuous nasogastric milk feeding versus intermittent feeding in preterms less than 1500 grams. And there was found no significant difference in somatic growth or incidence of neck if they were received continuous or intermittent feeding. Along with that, it was also noted that it is difficult to give continuous nasogastric milk feeding because you need very trained staff, you need continuous monitoring of these babies. However, I think some of the Scandinavian countries still follow continuous nasogastric milk feeding in some of the units. But the literature shows that it doesn't make much of a difference. So if we are going to start feeding our babies, if we are going to start giving them minimal enteral nutrition, how long do we give minimal enteral nutrition? When do we start increasing or progressively increasing enteral feeds? That was the second question. So a lot of studies have again come up who have, if you can see in the third column, that they have started this minimal enteral nutrition on day 2 or day 6 versus day 6. Some studies within first 48 hours versus on day 5. So less than 5 days versus days. So you can see in the third column that the minimal enteral nutrition has been given at various duration. And then how much this minimal enteral nutrition was given, we can look at that. And these are all the babies who were antenatally diagnosed, especially in the first 3 studies. We are going to talk a little more about the ADAPT study, which was a beautiful study which was done in UK. Again, this was abnormal Doppler's enteral prescription trial that was done in 2012 on 404 babies with abnormal Dopplers, and they had started feeding them on 12 ml per kilo per day in the first 24 to 48 hours. Tariagani, he had done a study wherein he fed less than 1 kilo babies with 6 ml per day, more than 1 kilo babies with 12 ml per day. Again, these were all with abnormal Dopplers. Tiwari et al., this is again another study which has recently come in 2018, done in one of our army hospitals, and wherein they have done the similar way as in ADAPT study, and they have given less than 1 kilo 10 ml per kilo, more than 1 kilo 20 ml per kilo minimal enteral nutrition. Again, these 2 studies which have come, Botscott et al. In 2018, which was published, they had given around 20 to 25 ml per kilo for the babies less than 1.25 kilo babies. The last study by Salas et al., of course, this was really, means for a 20, the mean age of the babies was 26 weeks with mean weights of 832 gram. And they gave minimal enteral nutrition for 4 days versus they started early enteral feeding at 24 ml per kilo right from day 1. So the first 4 studies, if you look at, the conclusion was there was no difference in the incidence of neck or feeding intolerance or the combined outcome, whether they were started early and if they were, that is within first 24 to 48 hours, and the various volumes of feed, that is even at the as much as 10 ml per kilo and 20 ml per kilo more than more than 1 kilo babies. So this is what these studies point out, except for this Salas et al. Study wherein they have concluded that early progressive feeding is not feasible in critically ill babies. The ADAPT trial, which I had talked about earlier, in that the babies with abnormal Dopplers with enteral prescription trial, they had started them feeding in the first 24 to 48 hours, or those with more than 5 days with 12 ml per kilo per day. And the rate of advancement, there is a separate chart which I have not put it over there not to confuse everybody. But what I want to point out is the further analysis of that study which was done. And this was done in babies who were less than 29 weeks, who were grouped into early feeding and the late feeding. And these babies were given 12 ml per kilo starting on day 1, or those who were given on starting on day 5. And if we look at this gray shaded area is which what is expected for these babies to reach if they was to receive that tolerate that much amount of milk within the first 8 to 10 days. However, in the early feeding, and they were expected to reach by 15 to 16 days in the late feeding. However, if we look at this graph, we see that none of the babies, whether they were in early feeding or late feeding, less than 29 weeks, did not meet the target what was expected because of the issues which they had. And I'm not going to talk about feed intolerance because that is going to be the next topic which is going to be discussed. So because of that, they did not reach to the expected, they were not able to tolerate the milk what was expected during that duration. So that is one of the outcome which came out of the ADAPT trial for babies less than 29 weeks. I cannot go forward without recognizing this work which has been done by one of our colleagues, Dr. Vishwanath Kamoji. He has done this study on antenatal umbilical Dopplers and the outcome on that is with regards to NEC, and on 243 preterm babies, and they have found the risk of NEC as much as 5 times more. So these studies were indicating that are we doing the right thing by, okay, we have to start with them a minimal enteral nutrition, but then how are we going to progress further? And this is when the Cochrane again review came in 2013 on early trophic feeding versus enteral fasting for very preterm or very low birth weight infants, in which there were 9 trials, 754 preterm or very low birth weight babies. And it did not provide a good evidence that early trophic feeding affected feed tolerance or growth rate. So what it means that early trophic feeding was safer. It was not increasing the incidence of feed intolerance or NEC in these very low birth weight babies if we started it early. Then there was another beautiful study which came, the SIFT trial in 2013 to 15. In this, again, this was done in less than 1500 grams babies, of which 204 were with abnormal Dopplers who received fast feeds. So they were started on minimal enteral nutrition, and then the feeds were advanced at the rate of 30 ml per kilo per day. And then there were those 226 babies who were whose feeds were slowly advanced at the rate of 18 ml per kilo per day. And they did reach, it was found that they were able to reach the target at 7 days versus 10 days by doing this early versus fast versus slow feeding. However, there was no difference in late onset sepsis or necrotizing enterocolitis in this group. And if we look at this forest plot, which is the this was a subgroup analysis of the primary outcome of the SIFT study, which was done, because the SIFT study was basically looking at the moderate or severe neurodevelopmental disability in case of babies who received fast versus slow feeding. But this was a subgroup analysis which looked at that, and it has shown that it does not affect much when it comes to necrotizing enterocolitis. So, but the important thing is, they said it was not cost effective. So whether we did fast feeds versus slow feeds in babies less than 1500 grams, they said it was not cost effective. So then there was this, because the number of studies which have been done in this decade basically, and I'm just going to mainly talk about this Cochrane database because cannot cover most, but important studies I'll be coming to later. So what this was analysis of delayed introduction of progressive enteral feed. So if we start with MEN, then how do we progress? Do we start early after 48 hours, or do we wait till 5 days? And is it going to prevent necrotizing enterocolitis in very low birth weight infants? This was this of 13 trials with 1,106 infants, and there was found that delayed introduction, though it did not affect the mortality, it did not affect necrotizing enterocolitis also. No, it did not affect the time to establish oral feeding or weight gain. So though this was not very clear in this, it was there was one more analysis which was done regarding slow advancement of enteral feed volumes. So here it was looked at whether we should introduce progressive enteral feeds early or late. And here it was looked at whether how much is the feed volume that we should enhance. Again, this was analysis of 6 trials, 618 infants, and this showed Cochrane database analysis showed that slow advancement took significantly longer to regain birth weight, somewhere between 2 to 6 days, and to establish full enteral feeding. So if we look at both this, the message which comes is early feeding, minimal enteral nutrition and advancing the feeds early does not lead to increased incidence of necrotizing enterocolitis. However, if we slowly advance it, we may have longer time to regain birth weight and to establish full enteral feedings in this baby. And this is the forest plot, which looks at, one is looking at the necrotizing enterocolitis, and this is looking at the mortality of these babies who were fed early, or delayed versus early introduction of progressive enteral feeding. And it shows that there was not much difference in both the groups. So then coming to, okay, so we can start a progressive enteral feeds early. So we have understood it so far. How much should be the volume of the feed that we advance? And here comes number of studies which have been done. I have just taken up a few important one of them and some which have been done in our own country. One which was done as early in 2004 by Salotra and Ramji, wherein they had enhanced the feeds at the rate of 30 ml per kilo per day, and they said that it is well tolerated. Another one by Modi et al. In 2015, where they looked at 750 to 1000 gram babies, as small as that, wherein they initiated at 15 ml per kilo and advanced by 15 ml per kilo. This they had four groups. They had made four groups of babies. So one 750 to 1000 grams, they initiated 15 ml per kilo, advanced by 15 ml. Other group, they initiated 30 ml per kilo, advanced by 30 ml per kilo. Then those between 1000 to 1250, they started at 15 ml per kilo, advanced at 20 ml per kilo. And this group, they started at 40 and advanced at 40. They found no effect with regards to mortality or feed intolerance. Similar study wherein they compared high volume of feeds, rapid versus slow enhancement, they found that there was higher feed initiation and advancement of volumes were appearing safe and well tolerated in babies who were less than 1000 grams. Yeah, there was one more study between this same age group, 750 to 1250, wherein they advanced by 20 ml per kilo versus 30 ml per kilo. And they found that rapid enteral feeding will reduce the time to reach the full enteral feeding. And this was another beautiful study by Jain et al. Vijay Chandigarh has done a lot of work with regards to enteral feeding in case of very low birth weight babies, and this was one of the study which they have come up with, wherein they had enrolled 30 babies less than 1250 and 53 more than 1250 babies, and they initiated feeds in them as early as 6 hours, so between 6 to 72 hours. They started at 10 ml per kilo for less than 1250, advanced by 20 versus 30 ml per kilo. And those who are more than 1050, they started with 20 ml per kilo, minimal enteral nutrition, and then advanced by 30 versus 40 ml per kilo. And they found that those less than 1250 babies, to gram babies, this the if it was advanced slower in less than 200 and 1250 gram babies, they were discharged earlier and at shorter post-conceptional age. However, there was no difference in feed tolerance in any of these groups. So, overall, if we look at the conclusion which is coming out from these different studies, is what the Cochrane analysis had said: slow advancement took significantly longer time to regain birth weight and to establish full enteral feeding. However, in Jain et al. Study, they have shown that they can be discharged earlier if they were there was a slow increase in the feeds. So again, there was another meta-analysis which came in 2017 on slow advancement of enteral feed volumes to prevent necrotic enterocolitis in very low birth infants. Looked at 10 RCTs, 3,753 infants, of which 20% had abnormal Dopplers. And they found that slow versus rapid advancement, there was no effect on risk of NEC or death. Slow feed advancement delayed establishment of full enteral nutrition by about 1 to 5 days, and it may increase the chance of invasive infection. And this was the forest plot of that Cochrane database analysis, which looked at the necrotizing enterocolitis, as well as it looked at this was for invasive infection, this forest plot, and it showed that the babies who were in the faster rate had lesser chance of having invasive infection than those in the slow group. But the mortality did not have, there was not much difference with regards to mortality. So now we know that we can start minimal enteral nutrition, we may start progressive enteral feedings earlier, and we may be safe to start rapid advancing the feeds. However, Is there any way of prediction? And Dr. Abhishek may touch upon this. So I have just one slide that I'm talking about, wherein this study was by Martin et al. In 2018, and they have started looking at feed-related splanchnic oxygenation in preterm infants with abnormal antenatal Dopplers, and they have shown that this could be a good tool wherein it can help us to pick up those babies who may have feed intolerance by using near infrared spectroscopy and looking at the splanchnic oxygen extraction in the babies who have started on enteral feeds. One more study again from PGI Chandigarh, Bora et al., done on the superior mesenteric artery flow. This had come as early as 2010, and they had come with a conclusion that probably serial SMA flow studies, especially 60 minutes post feed, may help us in predicting those babies who may have feed intolerance or GI complications if and when we start increasing their feeds. And then, so we know this about absent and diastolic flow. The study which was done by Jain et al., I did not mention it over there, was specifically for babies who had absent and diastolic flow in the antenatal period. They had excluded the babies who had reverse and diastolic flow. And our own colleague Aradhya et al., this beautiful study which they have published very recently, this is a retrospective cohort study wherein they have looked at the feed intolerance in those neonates with antenatal reverse diastolic flow. So this is specifically with those who had reverse diastolic flow, and they have reported that early enteral feeding as early as 24 hours can be initiated in those who had reverse diastolic flow during the antenatal period, but they need to be carefully monitored for abdominal symptoms and signs, which will be discussed in the next talk. And of course, the incidence, the risk of NEC was not found to be higher than what it was seen in those who had absent diastolic flow. So this is a very good information that we have got from this particular retrospective study. So, having known about minimal enteral nutrition and how early we can start it, we are now going a further, even earlier, talking about oropharyngeal colostrum swabbing in case of preterm infants who may not be who may not be ready to receive minimal enteral nutrition because of various issues, and maybe because of hemodynamic instability, ventilation as such. So, however, this particular Cochrane analysis of study done in 335 preterm babies with gestational age between 25 to 32 weeks, birth weight as low as 410 to 2500 grams, has been non-conclusive. So there is still a lot of work which needs to be done in this particular area, but they have found that it has got, they found that there was no evidence to show that it can affect the incidence of NEC or incidence of infection or death before discharge. So still a lot more information needs to be need to come or to build up the evidence whether this is going to be protective towards the preterm babies. Now, what's new with regards to feeding the low birth weight babies? We have so far understood that stable preterm babies born more than 32 weeks of gestation, birth weight more than 1500 grams, can be treated very similar to well-term infants. We start them with enteral feeds and then we can just progressively increase the enteral feeds. We are not particularly worried about these babies because we know that they can tolerate and they have less feed intolerance. Extreme preterm less than 28 weeks, extreme low birth weight less than 1000 grams can receive minimal enteral nutrition followed by progressive enteral feeding. What should be the volume? How early? We have discussed. But then there is one more group which is between 28 to 32 weeks and birth weight between 1000 and 1500 grams. And it has been found that there is a lot of variation in practices with this group, which forms a major chunk of our low birth weight or very low birth weight babies. And this is the group which is at the risk of complication because of parenteral nutrition, and if we are able, if we at all lead to delay in establishing gastrointestinal physiological, endocrine and metabolic maturity in these babies if we do not concentrate on their feeding. And this is the group which still needs a lot of attention. And this is one study which has now come up. This is done in our own country by Dr. Sushma Nangia, published in 2018. Most of us must have read it. And what they have done is early total enteral feeding in stable, very low birth weight infants. So what they have done is they did this study in 3 phases. In the first phase, so these babies are between 28 weeks to 34 weeks. They are stable babies. They do not have abnormal Dopplers in the during the antenatal period. So in the first phase, they looked at these 76 babies who received a standard management, what is being done in most of the units, that we start with IV fluids and then we start with slow enteral feeds. So we reach to full feeds by around 14 days. In the second phase, on 51 babies in this group, they started early enteral feeding. So basically they started them on 80 ml per kilo right on day 1. So it could be either mother's own milk, or if not, the formula milk which was used, and it was found that they achieved full feeds by as early as 8.7 days. Then they did a third phase of study in the same group wherein 84 neonates were enrolled and looked at the sustainability. Can really we do this? And they have found that we can achieve full feeds in these babies as early as 5.4 days. So the conclusion from this study is, in stable preterm very low birth weight infants, early total enteral feeding is safe. It has the benefit of optimizing nutrition. We need not start them on parenteral nutrition, and this can lead to decrease in sepsis and of course NEC and hospital stay. So this is a very important conclusion that has come out of this study. And that's why now we are looking forward to the Cochrane review, which is awaited on early total enteral feeds. It is going to be done, and let's wait and see what is the conclusion, whether it is, and they will give us provide the evidence whether we can start these babies as early as first day on total enteral feeds. There is one more study for which we are still waiting the reports, is the MAGPIE study. This is the study on mechanism. This is the which looks at the mechanism affecting the gut of preterm infants in enteral feeding trials. So in this, they have enrolled those same babies who were enrolled in the SIFT, SIFT, and there was one more ELFIN study which was done in UK. And they are looking at the gut microbiota which is excreted in the stools of these preterm infants, and that is what is being analyzed, and they're looking at how healthy it is depending upon the volume of feed which was given, how early the feed which was started, whether it was whether that improved the gut microbiota of these preterm infants. So this is going to be another interesting study to look at the evidence, which is again going to give us the enough rationale to start them on early total enteral feeds. So having reviewed this literature so far, let us look at what is the indication just of minimal enteral nutrition. That's the topic which I'm going to talk about. We know all the babies less than 32 weeks, very low birth weight babies, MEN is indicated. The only contraindication is if they are hemodynamically unstable, or if they are suspected or confirmed NEC, or there is evidence of intestinal obstruction. Mechanical ventilation, umbilical lines are not contraindications to start on MEN. What to feed? No doubt, as much as possible, express breast milk. The number of studies which I had talked about earlier, some of them have used donor human milk, some have used preterm formula, some have used term formula. Which one of them is the best, or there has not been a very conclusive evidence with regards to feed intolerance, but we know that if express breast milk is available, that is the best option. If not, the next better option is the donor human milk. And some of the studies, they have used a formula milk and have not found any increase incidence of feeding intolerance. How early? As early as 12 to 48 hours. In the PGI study, they had started as early as 6 hours also. So what I have written in red over here is the recommendations which are there from NNF clinical guidelines published in 2020, this year, January. So there is a set of 19 questions which have been answered in that review. Excellent review by our own people, which they have done, and they have answered 19 questions with regards to feeding low birth weight. And those who I request, those who have got more questions regarding after my presentation, can refer to that review as well. So some of those recommendations I have picked up over here. One is this recommendation by NNF: early trophic feeding to be started within 24 hours life in case of preterm low birth weight infants. Next is how much to feed. So now looking at the study, we have come to the study suggests that infants weighing less than 1000 grams, we can start minimal enteral nutrition at 10 ml per kilo per day, and maybe advance it by 20 ml per kilo per day after 2 to 3 days. After at the end of 48 to 48 hours, we can see clinically, examine the baby, decide, and if we feel stable, baby stable, start advancing. Those who are more than 1000 grams, we can start at 20 ml per kilo per day and advance as rapidly as 30 ml per kilo per day. Again, what I've written here in red is what is the NNF recommendation. Daily feed volumes are to be increased by 30 to 40 ml per kilo in stable preterm very low birth weight infants with no signs of feed intolerance. That is what the NNF recommends. By NNF, stable preterm very low birth infants may preferably be initiated on progressive enteral feeding from first day of life. So clinically, we can assess these babies and then decide about advancing the feeds in them. Coming to those with abnormal Dopplers, and especially this we see in less than 1100 grams babies, we need to monitor them closely for feed intolerance, but there is no evidence to delay feeds in these babies. So we can treat them just like any other babies, but with close monitoring. However, in those, some of the studies we are pointing out those less than 1250 grams, it is better that we are slow in advancement rather than rapidly advancing with regards to feed intolerance, but it may lead to delay in establishing full feeds, and we may be subjecting them to increased incidence of infection. So the call over for those babies, it depends a lot on clinical scenarios. So what are the advantages of minimal enteral nutrition? We all have looked at the studies, pathophysiology also. It helps in growth of intestinal mucosa. It increases the release of hormones with trophic effect on them. There is a greater absorption of nutrients, better lactase activity, decreased intestinal permeability, hence less risk of neck, and maturation of intestinal this muscle as well. The motility also is better by giving MEN. It has got vascular effect in terms of postprandial decrease in splanchnic resistance, thus increasing the intestinal flow and oxygen uptake. It also leads to good endocrinal effect in terms of increased enteroglucon, gastrin, or GIP. And of course, the clinical benefits of MEN, which most of the studies are pointing towards, is reduction in mean days to full, number of days to full feeding, decreased hospital stay, reduction in systemic sepsis, and a faster weight gain. So what is my take home message regarding feeding low birth weight infants? Mom is the best. Mother's own milk is the best. Minimal enteral feeding is safe and beneficial with early establishment of feeds, reduced length of stay, and reduced use of parenteral nutrition. Early and rapid enhancement is safe with close monitoring. For extremely preterm or extremely low birth weight babies, there is no good evidence to support delaying the feeds excessively, and minimal enteral nutrition can be started once the baby is hemodynamically stable. Stable, very low birth weight babies tolerate early advancement to full feeds, so we can be aggressive with the feeding these babies. In presence of abnormal Dopplers antenatally, initiate the feeds and advance feeding with close monitoring. Optimal duration needed to establish full enteral feeds still remains unclear in this group, and more studies are going to make it clear which in the upcoming days, but it should be based on baby's clinical response. So I hope I have made myself clear with regards to this topic today. And today being the International Nurses Day, let's wish our nurses from all our NICUs, who are the backbone of our NICUs, to stay safe, stay well, and to all of us as well. Thank you for your patient listening.
Thank you very much, ma'am. You can stop sharing the slide. So we'll quickly move on to the next session by Dr. Abhishek Phadke. And then once the presentation is done, we will go for discussion, ma'am. You can stop sharing the slides, ma'am. Yeah. Abhishek, please start sharing the slides. Over to you.
So first of all, I'd like to thank NNF for giving me an opportunity to talk on these two important topics. So one is on feed intolerance and second on GR in neonates, the diagnosis and management. So before we know what is feed intolerance, we should know what is feed tolerance. So it is basically the ability of the newborn to ingest and digest milk without any complications. Feed intolerance is defined in various ways in many articles, but the most practical one, what I felt is this: it is the inability to digest enteral feedings presented as gastric residual volume of more than 50%, abdominal distension or vomiting, and with the disruption of the neonate's feeding plan. It is a very subjective term. There is no clear-cut criteria. And because of this, it is one of the most common diagnoses in the NICU. Let me begin with a case scenario. A 27-week preterm infant weighing 900 grams, delivered due to cervical incompetence, received surfactant by Inshore and administered nasal CPAP with minimum settings. Day 1 started on MEN and TPN, feed slowly escalated. On day 3, baby is on 7 ml third hourly OG feeds with EBM, and nurse notices 3 ml feed aspirates, which is of this color, with mild abdominal distension, not passed stools after passing on day 1. So this is a very common scenario we see in our NICU day in and day out. So what is the next step regarding feeding? So probably the postgraduates can answer in the chat box. A, will you withhold feeds for the next 24 hours? B, shall continue feeding and watch closely. C, will withhold feeds, do investigations, X-ray, sepsis workup, etc. So what do you think is the most logical way of handling this situation? So this is a classical case of feed intolerance where you get a few gastric residuals on 2 or 3 occasions. So let us understand the signs and symptoms associated with feed intolerance. So the common symptoms could be the vomiting, that is altered milk, bile or bloodstained vomitus, and lethargy, apnea, temperature instability. And the signs, what we generally see is increased gastric residuals. Generally, it is defined as more than 5 ml per kg or 25 to 50% of the interval volume for 2 to 3 feedings. So this is considered as significant gastric residual. And usually it can be associated with abdominal distension with or without visible bowel loops, reduced or absent bowel sounds, and other systemic signs, cyanosis, bradycardia, etc. So these are usual signs and symptoms that we see in a baby with feed intolerance. Now coming to the gastric residual volume, many times there's a lot of confusion, what is significant, what is not. So generally the accepted concept is this, that is with the volume and color, volume more than 5 ml per kg, birth weight of the baby, or 25 to 50% of the interval volume for 2 to 3 feedings. Color, milky green, milky color is good, yellow green is bad, blood tinged is always bad, but sometimes it can be because of the indwelling catheter. that is a orogastric tube, which can cause irritation to the mucosal lining. So a lot of studies done on this to know whether it is really a marker of feed intolerance or NAC, and most of them have shown it as a good marker of feed intolerance. And the bloody residuals, that is blood in the gastric aspirate, seem to be the best indicator for or predictor for NAC. As we discussed, gastric residual volume of up to 5 ml per kg or up to 50%, it is generally wise to push it back, and if it recurs, subtract the residual volume from the current feed. But if it is more than 5 ml per kg or more than 50% of the previous feed volume, even then you can push the GRV back and then stop the current feed. And if it happens again, consider slow bolus feeds or withhold feeds depending upon the clinical condition. Again, this is our own Indian study which was done in 2015. And use the smallest volume syringe for checking residuals, because the larger the syringe, more will be the mucosal injury and high chances of getting blood in OG tube. Aspirate gently, which is very important. We should train the nurses. Consider decreasing the feed volume to the last well tolerated feed volume, which is very important in case if you want to restart the feed. Isolated gastric aspirates, never jump to withhold feeding. Always avoid excuses for withholding feeding. Instead, find reasons to continue feeding. And isolated gastric residual volume does not have much importance unless it is associated with other warning signs such as bilious vomiting, abdominal distension, or occult blood in the stools, or gross blood in the stools, or other systemic signs like apnea, bradycardia, or temperature instability. Only then it becomes significant. Always remember that. The second classical sign we see in a baby with feed intolerance is vomiting. Again, it could be because of the gastroesophageal reflex, about which I'll be covering in the second part of my talk. And consider surgical conditions if the color is bad, yellow or green, or if the volume is too much. And other forms of presentation would be with the abdominal distension. Again, could be because of the CPAP belly, like in this case scenario which I showed, baby was on CPAP, and positive pressure ventilation also can cause distension of the abdomen. Or it could be because of the initial retention of meconium or lack of stooling after passing the meconium. Abdominal girth measurement will definitely help, and always watch for skin discoloration. Stool color and looking for bowel sounds, very, very important. Systemic features, apnea, bradycardia could also be associated with feed intolerance. Now, when it comes to management, Manisha ma'am has covered in detail most of the studies which have been published in literature. And first of all, try to identify the trigger for feeding intolerance. Is there a setting for the baby to have feed intolerance in the form of Doppler issues, or a pH, or if it is a IUGA baby? Look for infection. Or if you're planning for a blood transfusion, again, there is a setting for feed intolerance. And or if you're planning for exchange transfusion in a baby who has undergone exchange transfusion. So these will be the setting for a baby to develop feed intolerance. So always it's important to keep this in the mind. Second, positioning of the baby will always matter, and feeding strategies. So most of the aspect regarding feeding strategies has already been covered. So one is about the intermittent feeding versus continuous feeding in reducing feed intolerance. So a lot of studies done on this aspect, and they have found that there is no significant difference in terms of incidence of NAC, time to achieve full enteral feeds, or the somatic growth between the intermittent feeding and continuous feeding. So in that sense, intermittent feeding may be more advantageous because it facilitates the normal cycling surges of the gastrointestinal hormones. Whereas continuous feeding has an advantage of reducing the energy required, but there is a disadvantage that if we are pushing the feed through a infusion pump as a continuous feed, the quality of milk can change. So intermittent feeding is always preferable. When it comes to frequency of feeding, 2 hourly or 3 hourly feeding, lot of studies has been done. So by and large, it doesn't seem to make much difference. So there is not enough evidence to choose between 2 early or 3 early feed for infants weighing less than 1250 grams. And the nursing time spent on feeding was significantly less in the 3 early group. Feed intolerance, apnea, hypoglycemia, and NAC did not differ significantly between the 2 early and the 3 early feed group. And by and large, 3 early feeding is preferable for infants weighing more than 1250 grams, whereas those babies weighing less than 1250 grams, you can consider second early feeding. So now coming back to the same case scenario, this baby had this aspirate, and we wanted to decide what we're going to do. So now what would be the appropriate answer? Most likely I'd like to continue feeding and watch closely. So always look for reasons for restarting than stopping feeding. So next, how about advancing the feeding in this particular infant? Do you want to go 5 ml per kg, 10 to 15 ml per kg, or as fast as maybe 20 to 30 ml per kg? So slow advancement versus rapid advancement. Already madam had described about this article by Raban et al. In 2016. So which has shown that infants on rapid advancement regimens reached up to 1500 grams weight more rapidly in extreme low birth weight babies. And there is no effect of high versus low volume in terms of feed intolerance, NAC, or late onset sepsis. So what are the other strategies that can be taken to overcome this problem of feed intolerance? So identify and treat the underlying cause, if any. Next, the last resort comes at drugs. Various drugs have been used: erythromycin, lactase, insulin, metoclopramide, etc. And all of these are of unproven benefit. The role of probiotics is coming up in a big way, but still we are all not very convinced yet. So to summarize on feed intolerance, it's a diagnosis which is often overdiagnosed. Avoid excuses for withholding feeds, instead find reasons to continue feeding. Always identify and treat the underlying cause, if any. Standardize the practice of not taking gastric residuals during the first week of life. This is what we do in our unit. We tell the sisters, especially in extreme low birth weight babies, do not check for gastric aspirate at all. Because the more you check, more you'll find reasons for stopping feeding. So the next part of my presentation will be on the gastroesophageal reflux in neonates, the diagnosis and management. So GER is defined as retrograde flow of gastric contents into the esophagus. And it's an absolutely normal phenomenon in most of the preterm babies. And it's a physiological event. So studies have shown that healthy infants demonstrated episodes of reflux as high as 73 times per day. Can you imagine? So it's an absolutely normal phenomenon. So this is what we have to understand about basic thing about GER. And most of the babies are just happy spitters. So there's a wide spectrum of babies who are just happy spitters to the other extreme, where they develop gastroesophageal reflux disease, which occur when reflux of gastric contents causes symptoms that are troublesome in the form of failure to thrive, feeding problems, chronic respiratory disorders, esophagitis, hematemesis, apnea, or ALT. So pathophysiology in preterm infants, it is mainly because of the transient relaxation of the lower esophageal sphincter. And we know the various muscles, the crural diaphragm, which plays a very important role, which I'm not going to go into detail about this. So coming to the diagnosis, we should remember there is no gold standard investigation for diagnosing GER in neonates and infants. So detailed history and examination has a major role. The general movements, the behavior of the baby gives some clue that probably there could be a component of GER. The various gadgets that we have for diagnosis of GER is one. The old generation one was a contrast fluoroscopy. Then we have the esophageal pH monitoring, MII, which is a multi-channel intraesophageal impedance monitoring, which can be clubbed with the esophageal pH monitoring. Then we have the radioisotope scan, which always has been done since ages, and the endoscopy. So we'll go in detail about the utility of each of these investigations. Contrast fluoroscopy, again, where you put a dye into the baby's tummy and then look under the fluoroscope. So this has got a very poor sensitivity, high false positives, false negatives, cannot differentiate between clinically significant GR from insignificant one. Hence, it is of no great use in neonates especially. Esophageal pH monitoring. So in this, basically a tube is passed into the baby's esophagus, and it is kept at the lower end of the esophagus, and it is connected to a pH recorder which continuously documents the pH of the esophageal refluxed contents. So there is an index called as a reflux index, which is a cumulative time with an esophageal pH of less than 4 divided by the total duration of monitoring into 100. So generally reflux index more than 7 is considered abnormal, less than 3 is normal, 3 to 7 is considered as indeterminate. So there are some problems with the isolated esophageal pH monitoring. It is not a reliable method to diagnose GR, especially in preterm infants, because the stomach pH in neonates is rarely less than 4, owing to the frequent milk feedings and a higher baseline pH. So the abnormal esophageal pH does not correlate well with the symptom severity. Hence, its utility is doubtful, and it is not of great use, especially neonates. And people have even gone to the extent of checking the pH of the oropharyngeal secretions. Few studies have published, but ultimate result was that it has no temporal relationship with the GR and the symptoms of the baby. Coming to the multi-channel esophageal impedance monitoring with a pH probe. So this is a presently this is an investigation of choice in symptomatic babies with GER and with really troublesome symptoms. So it is a reliable and reproducible technique for diagnosing GER in preterm infants. So basically in this, a tube is passed and it measures the potential difference between the electrodes. So any movement of either solids, liquids, or even air is detected by the impedance meter. So it can be clubbed with the pH monitoring also. So again, the utility is very limited, only in really symptomatic ones who develop complications. Milk scan is an age-old study, and it's a radioisotope study done by mixing the breast milk or the formula milk with a small amount of tracer, and the baby is kept under the gamma camera, and you see for the reflex of the contents into the esophagus. Again, very poor sensitivity and specificity, and it is not at all an investigation of choice. Endoscopic evaluation would very rarely be needed in neonates. Smaller size endoscopes are available for use, but the problem is the operator experience, and even this has got a poor correlation between the severity of symptoms and the presence or absence of esophagitis. So indications for endoscopy would be mainly really symptomatic babies with the complications and suspicion of esophagitis. So again, there are insufficient evidence to support the use of histology for diagnosis or exclusion of GERD in neonates. Of course, when it comes to infants or pediatric population, the fundas are going to be different. But from what we have learned until now, the diagnostic gadgets have got limited role in the diagnosis of GER when it comes to neonates, especially preterm babies. So management of GER or GERD in neonates. First of all, why is it important? Because grossly symptomatic babies can develop feeding problems, and they might develop poor postnatal growth. Along with that, it has got other problems because of the associations of GER with apnea, desaturation, and bradycardia. A lot of studies have been done. Final conclusion seems, this seems to be more relevant, that reflex episodes and apneas are rarely temporally related. So GER does not prolong or worsen apnea. It just happens that the GER is more common in preterm babies, and apnea prematurity also happens in preterm babies. So it's more of a coincidence than a causation. So there is no evidence that pharmacological treatment of GER decreases the risk of recurrent apnea in preterm infants. What about respiratory distress and BPD? So again, the final conclusion is there is lack of relationship of GER to chronic lung disease. So a lot of studies have been done and published, and the people have looked at the presence of lipid-laden macrophages in the bronchoalveolar lavage, even detection of pepsin in the tracheal aspirates. But it seems like infants with BPD were more likely to have pH-only events. So in the sense they develop GER, but that is not in fact contributing to the BPD. So because of the various complications that can potentially happen in a baby with GER, we generally tend to overdiagnose or subject the baby to multiple investigations. But when it comes to the management of GER in a newborn, especially preterm, we have very limited options. Broadly, we can classify them as non-pharmacological management and pharmacological management. So among the non-pharmacological management, the most important and time-tested treatment is reassurance, which we all neonatologists are good at when it comes to reassurance. So for non-complicated reflux, no intervention is required. All that is needed is effective parental reassurance and parental education. Body positioning may help, especially head-up angle. Prone position, they say it helps, but there is a risk of SIDS. So it is not advocated by the Aspagan or the Naspagan because of the risk of SIDS mainly. The left and the right positions has been studied in many research work. So one study done in by Omari et al. Has shown that left lateral position had significantly less GER, higher proportion of liquid GER, and faster gastric emptying. Generally, we tend to think that right lateral has faster gastric emptying, but when it comes to GER, the benefit is more with the left lateral position. Feeding strategy, second hourly, third hourly feed, small volume feeds may improve GER. So apparently the studies show that second hourly feeding is better than third hourly feeding, and bolus versus continuous tube feedings, again inconclusive result, and no RCT has been used to compare the effect of continuous intragastric or bolus intragastric feeding on GER symptom or severity. Basically, feeding with continuous or intermittent feeding doesn't matter much when it comes to GER in neonates. Feed thickener have been used, xanthan gum, starch, cereal. Again, no benefit, in fact more hazard. Linked to late onset NAC, systematic review of RCT in term infants have proved that it might not be very effective. Then comes the elemental or extensively hydrolyzed protein formula. Again, role is inconclusive. So a lot of studies have been done. First of all, these products are very expensive, and instead of withholding mother's own milk for the baby, why do you want to subject to all these formula feeds? So definitely these are not indicated when it comes to neonates. Pharmacological management comes in the step 2 of treatment. Prokinetic drugs, various drugs have been tried, metoclopramide, domperidone, erythromycin. Bottom line, not recommended for use in preterm infants if the only indication is the treatment of GER. All these drugs has got its own set of side effects, and that is the reason it has not been used widely. Sodium alginate has been found to be useful in older infants and children, and but still it no studies on the effectiveness of sodium alginate as a medication when it comes to neonates, especially preterms. Acid neutralizing agents, no conclusive study on neonates. H2 blockers, rampantly used, but unproven medication, unproven benefit in neonates, especially preterms. And in fact, it causes more hazard in the form of increased NAC in several studies, late onset infections, and high risk of mortality because of increased infections. And it possibly causes alteration in the intestinal microbiome too. So bottom line, present evidence not recommended in neonates, the H2 receptor blockers. PPIs, few RCTs, both omeprazole and lansoprazole were ineffective in reducing GER in infants, even in term babies as well as preterm babies. So lansoprazole was associated with a high risk of adverse events. So not recommended in neonates. Basically, drugs have got a very, very limited role when it comes to management of GER in neonates, especially preterm babies. So it's more of non-pharmacological treatment which plays a role in the form of better positioning and changing the pattern of feeding. Surgical treatment is the last resort in only those babies who are terribly symptomatic. Nissen's fundoplication is well established as a treatment option in children, especially bigger kids, but role in neonates and younger infants is unclear. It's reserved only for selective infants who fail medical therapy or who have life-threatening complications of GERD. Infants with underlying neurological impairment, chronic respiratory conditions, repaired esophageal atresia, these babies probably can be considered for surgical treatment. Again, high risk of, high chances of surgical failure rates. Overall, there is lack of evidence when it comes to surgical treatment of GER in neonates. So with all this, my take to work messages, because you are already at home. So on the topic of feed intolerance, I'd like to say feed intolerance is generally overdiagnosed. Always avoid excuses to withhold feeding. Instead, find reasons to continue feeding. Identify and treat the underlying cause, if any. And when in doubt, always check your gut feeling about the baby's gut. And about gastroesophageal reflux, that take to work messages would be that it's a physiological event, especially in neonates and preterms, and it has got a really distinct presentation compared to bigger kids or even infants. There is no gold standard investigation for the diagnosis of GER in neonates. Non-complicated reflux, where the baby doesn't have any symptoms, generally no intervention is required. All that is needed is reassurance. And the non-pharmacological approaches are the first line of therapy. That is the reassurance, positioning, changing in the feeding pattern. These are the ones that are going to help in newborns with GER. Drugs are not routinely recommended except for grossly symptomatic selected babies. So I'd like to end my presentation with this slide. Generally, there is a lot of evidence-based medicine that is practiced, but in the topic of GER, what we see is evidence practice dissociation. Studies say one, but when we are desperate, we tend to use things which are not evidence-based. So this there is probably clinical practice beyond evidence-based medicine. Thank you.
Thank you very much, Dr. Abhishek. So now we'll quickly move on to the discussion. So I request Dr. Kumar, the moderator for today, to take up the questions from the participants. And I'm sure all of us, most of the practical doubts are clear with the presentation. Thank you very much. Over to you, Kumar. Kumar?
Good evening, everyone.
I think, Kumar, your voice is not clear. Your voice is not clear.
Great job. And there are a few questions, only a few questions. And the first question, hello, now, is it clear?
No, not that clear, not that clear. Can you speak a little louder?
Prashant.
Yeah, it's
Prashant,
clear.
is it okay now?
Yes, it's fine. Please go ahead.
Clear? Hello? Prashant bhai.
It's clear. Go ahead.
Both the speakers have done excellently. There are only few questions which people have asked. First question is to Manisha ma'am. Ma'am, home-based feeding strategies for preterm low birth weight.
Yeah, I saw that question. If we are sending preterm low birth weight babies home, that means they are stable babies. And if they are stable, that means they can be started on complete enteral feeding. And the best option, as we spoke earlier, is again the mother's own milk. So the preterm babies at home, mother's milk is the best option. I didn't understand what else the question was. I mean, how do we feed, or what should be the volume, or what is exactly the question that they want to know about it? Because if it's a baby who is to be fed at home, we expect that this baby is taking spoon feeding, at least, if not the direct breastfeeding. And if the baby is at home, then the baby has to be given express breast milk if the baby is not able to breastfeed.
I think most of the preterms, if they are admitted in NICU, they will have either expressed milk based on the weight, and they will be already taught how to feed the baby and total amount of milk that will be given to the babies.
Yes.
And if they are at home, they are above 1.8 delivered there only. I think most of them will be more than 1.8 will have either they are in direct breastfeeding or there will be expressed milk. So I think not very clear what they want.
Yeah.
And second thing, the next question is to Abhishek. I think he has already discussed. They have asked about third hourly feeding versus second hourly feeding, and his discussion was very clear. And babies weighing less than 1250 kgs will have second hourly feeding, and other than that, they will have third hourly feeding. It was very clear whatever he said. And the other one was continuous versus infusion versus bolus feeds. Abhishek. Abhishek?
Am I audible?
Yeah.
I think even that point was made clear that there is no significant difference when it comes to intermittent feeding versus continuous feeding. By and large, intermittent feeding is preferable over continuous feeding.
And the third question was also, you made it very clear, color of aspiration and its significance. You already showed the picture of normal milk aspiration, or if it is a blood, or if it is bilious, and what are the things to do. It was very clear. The next question is, nasojejunal feeding better than NG feeds for symptomatic GER? Is it okay, nasojejunal feeding?
What is it? I didn't get it.
Nasojejunal feeding, is it better than nasogastric feeding for symptomatic GER babies?
I don't think it makes any difference. I'm not aware if there is a difference when it comes to the nasogastric versus orogastric in relation to GER, because neonates are generally obligate nose breathers. So that is the reason we always prefer orogastric. So when it comes to neonates, definitely go for orogastric.
They're asking about they're asking about nasojejunal, not nasojejunal.
Yeah, again, very limited studies in literature. I don't think that would be helpful. Hello, am I audible?
Abhishek, yes, you're audible, Abhishek. I think
very limited studies comparing nasogastric and nasojejunal in relation to GER. So answer is still unknown.
Okay. And the next question is for you only. Hourly feeds, is it better than second hourly in GER?
Yes, small volume frequent feed is better when it comes to GER. But again, managing a baby on hourly feed is going to be more difficult from nursing perspective. But in a baby with really symptomatic GER, we can go for hourly feed. Studies have shown that that is more beneficial compared to second hourly feeds.
Why not stopping H2 receptor blockers for several months for GERD?
Yeah, H2 receptor blockers, when it comes to neonates and preterms, it is not indicated, not recommended in any of the studies because of the risk of late onset sepsis and necrotizing enterocolitis. But in case if you have already started in a baby with the symptoms, it is probably advisable to continue for a shorter duration, in fact maybe around 4 to 6 weeks, and then give a trial of stopping it. Do not keep continuing it for longer duration.
Okay, the next question is for you only. Whether starting probiotics in very low birth weight babies is justified? If so, which one to start?
Yeah, again, that's why in my presentation I put a question mark. Probiotics have been widely studied. A lot of studies, especially from Australia. Dr. Sanjay Patola has done very good work on probiotics in neonates when it comes to feed tolerance. But again, I don't have any personal experience in using probiotics in neonates, and studies are also not very conclusive. Probably Manisha madam wants to add on.
If you look at the studies with use of probiotics, it is being found to be safe as of now in case of neonates. And it has probably, the studies are indicating towards decreased incidence of sepsis in the babies who have been started on probiotics. Some units, they start with probiotics right with the first feed, and then they continue it till the babies reach 32 weeks, 34 weeks. That is the protocol some units follow. But exactly which probiotic, what is available in India, how much should be the dose, those things are still unclear as of India's picture is concerned. If anybody else has more experience with this or aware of more studies.
Next question is to Abhishek. What is the incidence of acute life-threatening event in GerdD, and what is the management?
Yeah, see, ALT, if I remember, the incidence is very less, maybe 0.5 to 1%. But when it happens, it is a serious condition. I have seen at least 2 to 3 babies in the last 2 years coming with ALT, but we were not able to prove that it is because of GR. This I'm talking about neonates. Yeah, when it when baby comes ALT, you have to manage the intensive phase. And once the baby comes out of it, always investigation for GR comes in the algorithm for ALT. So GR workup has to be done in any baby who comes with ALT.
And this question is to Manisha ma'am. Ma'am, what is the role of probiotics in prevention of NEC?
I specifically did not touch this probiotics topic because again, there is a lot of reviews which will need to be done with regards to that. So that's why I did not touch it. But probably probiotics haven't, to my understanding, it has not shown much safety towards prevention of NEC, duration of hospital stay, death before discharge. It hasn't affected much as per what I have read. But overall, they have been shown only to help in decreasing the prevention of sepsis. The late onset sepsis is found to be, probiotics have been found to be useful if started early. Yeah.
Next question is to Abhishek. What is the relationship between the feed intolerance and delayed bowel movements in extreme preterm infants? And what are the management strategies?
Yeah, see, like I told earlier, preterms tend to have gut immaturity and sluggish bowel movement. So definitely, yeah, a baby who has delayed bowel passage tends to have a bit of distension, feed intolerance. There is association, and common things like hypothyroidism or even surgical conditions like Hirschsprung's, these need to be looked for in a baby with delayed bowel movement. I remember during my training, we had a preterm baby, extreme preterm baby, had abdominal distension, feed intolerance, went on and on. The initial TSS screening was normal, but continued to have distension, feed intolerance. Then when we repeated the TSH, it was high. So baby had congenital hypothyroidism. So these aspects, common things should be looked for in a baby with delayed bowel movement, and definitely it warrants further workup.
Manish ma'am, this question is for you from Sidhu. In our places, there are a lot of C-sections, so that we have difficulty in getting mom. So what would you advise, whether it is a donor milk or a formula feeds?
Yeah, of course, mom is the best. In absence of that, if we don't have proper facility to get donor human milk with following all the rules and regulations which are needed to have get the milk from the milk bank, the safest option is to, I would start, if that is not available, I would start on formula feed. And a lot of studies are there where mom was not available, they have used formula feeds. Some have used term, some have used preterm, and they haven't found much difference in terms of feed intolerance. Yeah, so I would go.
Ma'am,
Yeah.
yeah, here there is option of donor milk also. When donor milk is there,
If it is
and
available,
formula
yes. If donor milk is available, yes. But he is talking about peripheral centers. So in peripheral centers, there may not be milk bank available. So if milk bank is available and if there is a donor human milk available, yes, that is the second option next to mom. But after taking proper consent from the parents, and if not, then the third option is formula feeds.
Next question is to Abhishek. 28 weeks gestation, weight 900 gram, and indication of preterm is mother PIH not, and baby is on feeds from day 3 at 3 ml second hourly. Baby vomits, feeds with no abdominal distension, and investigations are normal. How do you proceed?
Yeah, again, like I discussed earlier, look for reasons for restarting feed. If the baby is otherwise well, no abdominal distension, and has just vomited once or twice, I just continue feeding. Parallelly, probably I just work up because NAC, sepsis, all these things I have to keep in the mind. I'll work up for other causes, but I definitely continue feed if there are no other absolute contraindications.
Yeah, I agree with Dr. Abhishek with regards to that. I think this is based on the clinical examination of the baby that the call has to be taken. And most of the times, I think just by giving, after skipping 1 or 2 feeds, we can again restart these babies on feeds. There is one question here. If EBM is not available in C-section, what milk can be used as minimal enteral nutrition? Can I answer that?
Yes,
ma'am. Please go ahead.
Yeah. So
please go ahead.
Yeah. So again, as I had said earlier, there have been studies done when they have, in absence of EBM, they have used formula feeds also, and that has at this 10 ml per kilo rate, it has been started, and it has been not been associated with increased risk of feed intolerance. Of course, these are, but I think here I would look at the stability of the baby. If the baby is hemodynamically stable and mother's milk is not available, baby is ready to receive feeds. However, we do not have the option of donor human milk also. In that case, the third option is formula feeding.
There is one question here. We find a lot of benefits in controlling GER in infants of mothers consuming cow's milk by stopping mother's cow's milk consumption. So yes, like I put in the slide, CMPA, that is cow's milk protein allergy, is known to occur in mothers who drink cow's milk also, because protein can pass across the mother's milk into the baby. So yes, CMP always should be considered in any baby with reflux, and needs further workup. In case diagnostic tests are not possible, you can probably advise a mother to stop taking cow's milk for some period of time to see if there is any symptomatic improvement.
Yeah, and Dr. Sidhu has asked, consent is necessary or mandatory. I believe this is for donor milk. Yes, consent form is definitely necessary. Dr. Srinath, he had spoken about it in the talk on Sunday, that yes, we do need consent. And the next question is regarding feeding IUGR babies, how to go feeding with EUGR babies. Again, the literature review which I have shown is unless the babies are hemodynamically unstable, we can start these babies on ME and minimal enteral nutrition within first 24 hours of life. Probably for 48 hours, we can give that at 10 ml per kilo depending on the baby's weight, and then increase it at the volume of 20 ml per kilo, 20 to 30 ml per kilo, monitoring the baby very closely. So for any signs of feed intolerance. So there is no evidence to suggest that we should delay it excessively. If the babies are hemodynamically stable, we should start it as early as possible. Next is, at what amount of tube feed UV line to be removed? Is there any correlation? I have not come across that. There is no relation, in fact, between umbilical lines and starting feeds for the baby. There is one more question on moderate respiratory distress in hyaline membrane disease and moderate respiratory distress in meconium aspiration syndrome. Can we start direct breastfeeding on day 1? I think it all depends upon how the baby clinically is. A baby with moderate respiratory distress, you mean to say what is the respiratory rate of this baby? More than 60? Will this be able to will be able to start? Is a baby comfortable in taking direct breastfeeding? That's what we need to see, because we need to be careful about preventing aspirations if the baby is in respiratory distress. So we'll have to be careful in this regard.
I agree with Manisha ma'am. I think definitely in a baby with moderate respiratory distress in HMD has to be term, and a baby with respiratory distress in MS, I would not dare to start direct feeding on day 1. Probably I'd play it safe.
And next question is, ma'am, can we continue MEN for a baby who is on inotropes, minimal enteral nutrition on inotropes?
Yes, if the baby is inotropes, in the sense if the baby was hemodynamically unstable earlier, for which inotropes were started, but now the baby is stable and you are started decreasing the inotropes, then and it says more than 2, so more than 48 hours of age this baby is. So whole thing is, if the baby is clinically stable, the abdomen looks good, and then we can consider starting low volume of the minimal enteral nutrition in these babies. I would at least consider, if we are not high on inotropes after 2 days of life, and we are looking at the clinical stability of this baby. If that is so, we know that we are tapering down the inotropes and baby is going to be baby is showing the signs of improvement after 48 hours, definitely we should consider starting with MEN.
Ma'am, the next question is for you only. Do we need to take a consent to start formula feed?
In our unit, yes, we inform the parents when we start formula feeds for the baby. This is I don't see that, I mean, I don't know whether there is any definite guidelines for it, but yes, we inform the parents that this is what. Of course, for donor human milk, we take their written consent, and for formula feeds, we inform them, and if they have agreed, then we start with because nowadays we come across parents who are well read, who know what are the problems associated with this different milk that we can use. So we find it easier if we have informed them.
The next question is also to you, ma'am. Which is the best human milk fortifier, ma'am?
Human milk fortifier, yeah, human milk fortifier, it's a big topic again. It needs a complete discussion. There are various human milk fortifiers which are available, and what we have in India is we have Lactodex and Prenan, and probably some liquid human milk fortifiers also I heard are available. I'm not very sure. So these are what we have right now. We in our unit, we use either the Lactodex or the Prenan human milk fortifier. And that we start once the baby has, what the literature recommends is anywhere between 50 to 80 ml per kilo. Once the baby has reached to that intake and baby is tolerating. Earlier, the recommendations were you reach to the full feeds what the baby needs, like 120, 140 ml, and then start adding. However, the recent literature is very clear. They have said start adding HMF at the earliest, and maybe with 50 to 80 ml per kilo, if the baby is consuming, then we can consider adding HMF. It depends upon how much is the volume of the feed. So initially we can add half sachets and to the milk, and then if the baby is tolerating, we can start adding the one full sachet also to the milk.
Ma'am, that has more of calcium. Is it okay, ma'am? Rather than we concentrate on calories when we start HMF, and if it has more calcium also, because Lactodex has more of calcium.
I have calculated this calcium intake of the babies who are on HMF, and if we are not, see, the thing is, if we are giving HMF, if we are adding HMF to the mother's milk, we should not give any other supplementation. So that is what we have to be very clear about. And it does not really cross, I have not realized if it has crossed the recommended, what is the recommended intake for the calcium for the baby. So if, and of course it increases the calorie and protein intake, along with that iron also that we have to look at. So all those things we need to look at when adding HMF. But calcium, as far as I understand that, it provides the recommended calcium intake, and we don't need to add extra after that. Anybody else has any?
I agree with madam. Even the same thing we follow in our unit. Any baby whom we start on HMF, we don't add on calcium supplement. And generally, the calcium and phosphate doesn't cross the recommended intake for a preterm baby by adding HMF. It just becomes at par. So it should be okay.
Yeah.
Thank you, ma'am. And one more question, madam. In the market, we have a lot of enzyme drops. Any benefit of starting lactase enzyme drops, madam, which they say it as a nutrition or some digesting?
I have, at least I have not find any literature showing good evidence to use it. I have come across a few studies about it, but I have not found good evidence to say that it is useful.
As a placebo, then yes.
Placebo.
For whom?
I think these are the only few questions which both have answered very well, ma'am. Ma'am, thank you very much for your talk, and as well as Abhishek. Thank you for an excellent talk, both of you.
Thank you, Kumar.
I think
Thank you, everyone.
Thank you.
Guru Prasad sir has few questions. Guru sir?
Prashant, audible?
Yes, sir. Yes, sir. Yes, sir. Audible, sir. Please go ahead, sir.
Yeah. Manisha and Abhishek, you have done a wonderful job. I think it is nice that Sunday you planned an breastfeeding, then human milk banking, and subsequently this one. I think it has almost completed the nutritional issues of the newborn. I just wanted to add a nice discussion. I think the junior faculty, the junior practitioners, they tend to look at HMF, enzyme drops, some of those things. If you look at the evidence, the WHO guidelines that are prepared for developing countries are as old as 2011. Subsequent to 2011, we don't have feeding guidelines for low birth weight and preterm infants. And I'm happy to share that the NNF national chapter has come out with very clear evidence-based practice guidelines. And one particular chapter is dedicated to feeding of low birth weight and preterm infants. I request all the fellows and postgraduates to really go through, very well written and very nicely reviewed. So that is for the postgraduates. So if you read that, you certainly get very clear answers for enzyme drops, human milk, 45 years, all that. I think what we should remember is we have very little data from the developing countries as far as feeding practices of low birth weight is concerned. Here that we initially thought of doing a study along with our colleagues from Belgaum, Dr. Prasad Gowda, Dr. Manisha knows about it. We started looking at low birth weight infant feeding techniques. We wanted to have 4 arms and try all this. Then we realized we ourselves don't know what are the feeding practices in the community. Whatever we shared is only the hospital-based evidence or records. But in reality, if you go to houses, majority of our low birth weight babies don't even come to any of us. There are interesting facts and figures. I think we need to know about it before we really advise them what is the correct. But I think the take-home message is we are very comfortable with mother's milk, expressed mother milk. You can go up to 160, 200, 220 ml very comfortably. They showed phenomenal weight gain and excellent growth trends. I think that should be the take-home message. We should not mess up with adding anything else. Baby should not be shown the taste of it, anything other than the mother's own milk. That's what we seniors believe in that. I thank you for giving me this time for sharing my views. Prashant, you've done a great job. I think excellent topics of practical importance. As Abhishek concluded, probably GRD, we have to go with experience-based medicine. If you go strictly with evidence-based medicine, you get stuck. Feeding low birth weight infants is a challenge, and it tests the patience of the consultant. You can't hurry through. You have to be very patient. Sometimes you have to wait for 24 hours, 48 hours to make increments. Some infants will, each baby is a great learning exercise in the unit. I think each baby will teach us how we should start and how should we can't have 1 hourly, 2 hourly, 3rd hourly for different babies in a busy unit. You have to keep in mind the working nurses. In small hospitals, you can understand, like corporate hospitals. In medical college and district hospitals where there are 30, 40 babies, we need to have a protocol. Like we are very comfortable with 3rd hourly feeds. We have no issues. All infants gain weight the way we expect them to gain. Thank you.
Thank you, sir. Dr. Dinagar, sir. Dr. Devraj Raichu, sir. Do you want to give any inputs, final inputs?
Excellent, Dr. Prashant. Speakers were
Ma'am, I
really
think
done
there is
it.
only one question left.
Yeah, please,
Only
Kumar.
one question. Only one question. That is the last question. I think you already answered. Anand says we start HMF after 100 ml per kilo per day feed. But what is the ideal and latest? You already told that it is after 120 ml we can start. That's what you told, no, ma'am?
No, we can start even earlier. There are some studies which have started at 80 ml per kilo also now.
Okay. What is ideal and latest? What he asked, ma'am?
Yeah. So the studies show that even starting at as early as at 80 ml per kilo also is safe.
Thank you. Thank you very much, ma'am. Over to you, sir. Dinakar, sir.
Excellent speakers. Really from my heart I am talking. Monisha and Dr. Really Abhishek have done a great job. Abhishek, carry home message from Abhishek Padke. Have you seen anybody in India regarding GERD is doing MII, means multi-channel esophageal? Anybody has?
Yes, like
anybody we are doing.
Yeah, in neonates, definitely. Yeah, I do not think anyone would have done in neonates, but in bigger kids, infants and pediatric, yes, gastroenterologists they do it. But in newborn, I don't think it would be right to subject a newborn to these investigations for GER.
Yes, sir. Number one, because conclusion, whoever says in this time, they are the people they are going to listen and they are going to implement. Either in the periphery or they should not think, multi-channel is not there with the, there is something, they should not think. Number one.
Correct.
The second thing, if the GERD is there, how better one word, whoever till now they are saying and listening, one word. If they are either peripheral doctors who are practicing, pediatrician as well, neonatologists or finish the fellows or DMs practicing in that way. What better way in one word to diagnose GERD and one word position?
Yeah, yes, sir. For the diagnosis, it's mainly clinical, and management-wise, management-wise, if I had to use only one word, it is only reassurance. Just reassure the parents. Hello, sir. I cannot hear you.
No, you are audible.
Yeah. How to diagnose in one word? If diagnose, what is the position? What is one word treatment?
The diagnosis is definitely based upon, it's going to be clinical diagnosis. Do not subject the baby to investigations. Positioning, left lateral position and head up position would be ideal for prevention of GER.
Yeah, which position, sir?
Left lateral, sir.
Yeah, some in case if left lateral position is there, is it a good one or anything first half an hour or first half an hour right lateral?
Yes. Actually,
because carry home 3 points.
yes,
Position.
sir. In position, yes, sir. Study is say first 1 hour put the baby to right lateral so that there is more of gastric emptying that is going to happen. Then turn the baby to left lateral. But yes, in a busy unit, I don't think it would be practical. So that one nurse has to stay by the side of the baby, stay with the baby for half an hour to 1 hour in right position to facilitate gastric emptying, then turn the baby to left lateral. Yeah, that would be ideal. Turning the baby to right lateral for 1 hour and then turn to left lateral.
Okay. So what you are telling is first half an hour at least right lateral, then half an hour left lateral. If it is very difficult, supine position is better.
Yes,
okay.
yes.
Then only clinically diagnosis is more better than any subjective to anything. So
definitely, any day.
Yeah, in your topic GERD, that's all carry home message for whoever stays till this time. So regarding madam, what is carry home message till now was saying about your subject, Dr. Manisha Bhattacharya?
Yeah, as the first thing is mom, mother's own milk, feed the babies mother's own milk as much as possible. Start early. As for babies who are hemodynamically unstable, we may wait for 24 hours or 48 hours maximum, but start as early as possible on minimal enteral nutrition. Volume is 10 to 20 ml per kilo depending on the weight of the baby. Progressive enteral feeds, once a baby, no signs of any feed intolerance after 48 hours, start with progressive enteral feeds. Volume would be anywhere between 30 ml per kilo, that at least should be there. For even 40 ml per kilo has been found to be safe, but 30 ml per kilo of progressive enteral feeds. And monitor the babies closely for feed intolerance. As far as babies with abnormal antenatal Dopplers, it has been found that they can be started on minimal enteral nutrition if they are hemodynamically stable, and progressive enteral, there is no need to delay the progressive enteral feeds even in these babies if they are clinically stable.
Yes, madam, one question for you, carry home, because many 74 people still they are in the line, they are genuine still there. Number one, what you mean by just absent diastolic flow or reversal flow, or there is a problem in the diastolic flow? Three things. One is absent diastolic flow, another one is reversal diastolic flow, or uterine problem flow, which is they have to take it is a more significant.
As far as I understand, a reversal in the diastolic flow is what we were worried about all this time. And the recent cohort study, which has done the analysis, a retrospective study, they have done analysis and they have shown that even babies, of course, those with absent end diastolic flow, we can feed them comfortably. Those with reverse end diastolic flow as well, we can start with minimal enteral nutrition early, and we can increase it depending upon with close clinical monitoring. So these two, I mean, that is what I would be more concerned about. What is the... Yeah, have I answered your question?
Carry message, what you told, yeah, you told, because once again you told we can give the feeding in reversal, once again you told we can give the feeding in absent also, but what I understood, is it correct, madam? If it is a reversal flow, little go slow.
Go slow, yes. We have to go slow.
You can go ahead, there is no problem.
Yes, yeah.
Because later reverse. If it is reverse, even one day if you will delay, doesn't matter. Or 2 days delay. What do you mean by that?
Sorry, your voice is breaking.
Okay. See, madam, absent diastolic flow is there, means we can start feeding if at least after a day. If it is a reversal flow is there, at least we can start after 24 hours or 48 hours.
Yeah.
Is it what you are telling us? We can start early for flow.
If it is more than, sorry, the last question.
He's asking, ma'am, but if there is a reversal of flow,
Mm-hmm.
absent diastolic flow,
Mm-hmm.
you have
Okay,
to
ma'am.
wait
Can you hear me now?
48 hours, or you can start early. What is your take-home message? He's asking.
With regards to reversal of absent end-diastolic flow, you can start even before 48 hours. With regards to reversal of end-diastolic flow, you may have to look for the baby's hemodynamic stability and then start them on feeds. However, starting early, if I refer to that retrospective cohort study which was done, it was found to be safe. And then progressive enteral feeds even after 48 hours with the babies with reverse end-diastolic flow has been found to be safe. In my own clinical practice, this is what we follow. We start them on minimal enteral nutrition if they're clinically stable, and then progressively we start increasing after 48 hours if there are no signs of feeding intolerance. But of course, we have to go slow. May not be at 30 ml per kilo.
Excellent. Yeah. Go
Hello.
slow with the increment, start the feeding at least after 48 hours. Very nice. Over to Prashant. Excellent topic. Please, dear.
Yeah,
Dr. Prashant.
thank you very much, sir. Kotreshi, sir, would you like to add few things, sir?
Yeah. On behalf of KN Karnataka chapter, I'm very thankful for these two topics today. Very important for newborn care itself. The basics of by Manisha Banarkar and Dr. Abhishek Padike both presented very well on feeding pattern, duration, low birth weight, and even the risk babies, how to feed and what are the type of feeding. I'm very thankful for the both guests for giving a very good orientation on breastfeeding activities and feeding pattern. Thank you, sir.
Thank you, sir, for giving us the opportunity.
Thank you, sir. It was my pleasure.
I would like to thank again all the speakers, Dr. Manisha, Dr. Abhishek, and Dr. Kumar for moderating, and all the participants. And we were joined with all the seniors, Dr. Santosh Sir, Dr. Devraj Raichur, and many other people had joined. And I would like to thank all the participants who have been actively participating in all our academic session. Looking forward to see you all again on this coming Thursday. So please do join us, and all this recorded video will be posted on Facebook. Please do join. And Thursday, and then Friday we have our International Kangaroo Mother Care Day. So NNF Karnataka is going to celebrate International Kangaroo Mother Day. So we would love to see you first on Thursday, followed by Friday. Thank you very much for joining. Sir?
Introduce the speakers who are who is the speaker on Friday.
Sure, sir.
Please. So Dr. Wani, Friday talk, Dr. Wani, she is the mother of Kangaroo Mother Care. She is the one invented and established Kangaroo Mother Care committee or whatever it is there. She is the mother of Kangaroo Care. She is the one doing the TOTs of the KMC in India. She is going to talk, number one. And the second person is Dr. at present NNF KMC wing head, Dr. Somsekhar Nimbalkar is going to talk on Friday at 5 o'clock. Is it true, Prashant?
Yes, sir. Yes, sir. Yes, sir. And on Thursday, we have coming up with Dr. Fatehpur and Dr. Sunil. They'll be talking on neonatal growth monitoring and hypo and hypernatremia algorithmic approach. That's on Thursday. So Friday, it is Dr. Wani, the mother of Kangaroo Mother Care, the pioneer, is going to talk. Thank you very much, all the participants. We will catch up again on Thursday. Thank you all speakers. Thank you all participants. Thank you.
Thank you, Dr. Prashant.
Thank you.
Yeah, thanks, Abhishek. Bye.
Yeah, thank you. Bye.